Thanks so much, Scott, for joining us today.
Thank you. Happy to be here.
So the Crosstown Clinic is the first in North America to provide medical grade heroin. Explain how this came about and why those that made the decision thought it was important to do this.
Well, injectable treatments, mostly diacetylmorphine or prescription heroin, have been available in the United Kingdom, for example, for a century. And they have a take-home or a carries model in the United Kingdom for a few hundred people. It's a small number of folks. Our program, which is supervised or observed, providing prescription heroin syringes or hydromorphone or dilaudid syringes, comes out of the Swiss experience. And the Swiss recognized that there was a problem with public drug use in the late 80s. And they said, we need to try something else. Methadone is a great drug, but it doesn't work for everybody. And they didn't like the take-home model in England. So they said, we will try a supervised model, providing people syringes. They started that in the early 90s with support by multiple levels of government and community in Switzerland. And it was a success. They subsequently had 2 referenda supported by over 2/3 of the population in Switzerland, and they now have injectable diacetylmorphine integrated across the country and in the healthcare system. In the early 90s, people in North America recognized, well, we've got a problem here in North America as well. Maybe this is something that we need to look at. This clinic was a site of the first prescription heroin trial together with Montreal back beginning in 2005. That was the Naomi trial, North American Opioid Medication Initiative. It asked the question, is prescription heroin superior to methadone in the population that continues to inject despite attempts at methadone as standard oral treatments? Published in the New England Journal of Medicine in 2009, yes, it is superior. Unfortunately, we weren't able to transition to a program at that time, although Denmark looked at the results of that trial, said, oh, well, we don't even need to do any more trials. We're going to start prescription heroin now. It was so successful, that initial expansion. Denmark now has prescription heroin integrated across their healthcare system. There's several countries in Europe that have prescription heroin integrated in their healthcare systems now. But we weren't able to transition to a program in Canada, and it led to our follow-up study called Salome. And 10% of the people in the Naomi study were actually receiving hydromorphone or dilaudid. The researchers thought that, well, experienced heroin users aren't going to be able to tell the difference, and it probably won't work. But as an internal control, they used that in the study. But it seemed to work just as well, and people couldn't distinguish between the drugs in a blinded study. So Salome asked the question, is hydromorphone or dilaudid as good as diacetylmorphine? And that study ran at this clinic from 2011 until 2014. And yes, hydromorphone is as good as. We were able to transition to a program with hydromorphone in 2014. And subsequently, later in 2014, we were able to get diacetylmorphine as well, importing it from Switzerland. So we've been running a program with hydromorphone and prescription heroin out of this clinic since 2014. There are now at least 5 clinics and a hospital in the Lower Mainland area that are providing prescription heroin programs, and there are hydromorphone injection programs across BC. Including Abbotsford, Victoria, Powell River, Edmonton and Calgary have IO programs with hydromorphone. There's 2 in Ontario, 1 in Montreal, and soon to be 3 in New Brunswick. New Brunswick's doing amazing work. So they've got clinics in Fredericton, St. John, and soon to be Moncton.
Okay. And for the common person like myself, Scott, explain what the difference is between medical grade heroin and the street drug heroin, because what I hear is it's a drug, period. So describe the difference for me.
Well, what we're providing is a pharmaceutical. So it's sterile, predictable, and individualized dose in a medical setting. And then it's perfectly safe when people are provided prescription heroin or diacetylmorphine or Dilaudid or hydromorphine in a medical setting. People can take this for years, work, care for their families. It's another tool in the toolkit for managing opioid use disorder. When somebody accesses the illicit stream of opiates, they may think they're getting heroin, but it's mostly fentanyl now, and it's not sterile, and the dose is not standardized. So people wind up poisoned or dead. Yeah. This isn't just a drug, it is a treatment. Okay. And prescription heroin can change people's lives for the better.
Tell me about how you've seen people's lives change through this.
Well, it can be extremely dramatic. I can see somebody in one day who's living in a box under steps and who has housing and not accessing street opioids within a week. Mm. So the change can be transformative. And this sort of gets to one of the major benefits of the program, which is reducing crime, reducing public disorder. If somebody's accessing street opioids on a daily basis, they have to engage in activities in order to get that fix, in order to feel well and not be sick. If we provide people with an alternative medication, methadone, Suboxone, and in some cases prescription heroin, they no longer need to engage in street activities. And we've got evidence from our trials that this reduces crime, both property crime and violent crime. So it really comes down to a public safety issue.
Yeah. Do you think this is the answer to this national epidemic that we are seeing with opioid overdose across our country?
I don't think it is part of the solution. We need more options for folks, more tools in the toolkit, and different routes of administration. We have Suboxone, we have methadone, good drugs that work for most people, but they don't work for everybody and not all the time. And there's now Cochrane Review, multiple randomized controlled trials showing that prescription heroin or hydromorphone are able to attract and retain a small but significant group of people in care when other things have not worked. And we also know from the experience in Europe, like Denmark and Switzerland, this is totally scalable. It can be incorporated into healthcare systems, and Health Canada could do that. And Canada could do that. Any of the provinces could expand this. Recently, Health Canada has approved a domestic supply of diacetylmorphine. So a company called Pharmascience, as of mid-February, is producing 5-gram vials and 200-milligram vials of diacetylmorphine. So prior to that, one of the barriers was there just wasn't a Canadian supply, but now there is.
What's your response to those who think, having harm reduction sites or overdose prevention sites in communities is actually harming the community, the NIMBYism that we hear of? What's your response to that?
Well, this is care. It attracts people into care who are accessing street opioids, and when they're given an alternative, the associated crime disappears. This reduces crime. One example is the Vancouver Business Improvement Association was not keen on the idea of starting Naomi, but when they saw the results, and they're now supporters. Because they're frustrated, the businesses, with people using drugs and leaving paraphernalia in doorways. If people have an alternative, they access it. They come to the clinics like this. So I'm not. If people are given the education and the information, we've seen the NIMBYism go away.
We talk about, and I appreciate what you said about the different solutions to this problem. Talk to me about what you've been seeing in the last 5 years when it comes to fentanyl and this wild card, essentially, that has attributed to over 25,000 deaths in the last 5 years across our nation. Just the unpredictability of this drug, fentanyl.
Well, the street supply has just become more potent and more toxic and cut with more compounds like benzodiazepines, for example. So we've had to adapt some of our protocols. Mm. So when people present at our clinics now, their tolerance is just higher. Mm. So back in our research trials that we used to start with a dose of 15 milligrams of diacetylmorphine. That just, with the current tolerance and the current potency of the street supply, that's just not sufficient to give people the relief that they need. So we're starting now at 50 or 100 milligrams of diacetylmorphine. Wow. And we've seen that that's safe, but it's also what's required to make people feel well and make sure that they want to come back to the clinic.
Yeah. Describe for me, this is my last question, describe for me the process. So someone would come into the clinic, describe for me how you would assess how much of medical grade heroin or the other drugs that you would give to the clients. Yeah, just walk us through that.
So we work with an overdose outreach team to assess who might be appropriate for the clinic and support people to come in. Many of the folks that we see will have bad experiences with healthcare. So one of our jobs is to build trust and relationship. So, and that can take time. But one way to do that is offer people something that they're seeking that will give them some relief. We used to have a standardized protocol that started low and then went up to 180 milligrams. I now have what we would call fast, medium, and slow. So we could start at 100 milligrams, go up to 200 in one day, start at 50, go up to 200 milligrams in a couple of days, or even start at 50 and go even slower over 2 or 3 days. And if somebody comes in, we can talk about their history. I can make a recommendation, but we can include people in that decision-making, shared decision-making, so that people can have some autonomy and control over their care. And that seems to help, because people know, I think I've got a high tolerance and I'm using a lot on the street. I'd like to go with the faster option, or hey, I'm not using that much. I think I'll go a little slower.
And is the goal to, as you talked about, to help people to maintain and be functioning, or is there conversation around detox, going into treatment? Is there any conversation around that?
This is part of a continuum of care. Yeah. And just like methadone or Suboxone, this could be treatment for life for some people, but for many people, once they're here for a few months, they'll start reconnecting with their families, maybe working part-time, and then it's inconvenient to come here 2 or 3 times a day. So naturally people will, in many cases, say, oh, I'm ready to try Cadian, or I'm ready to try methadone. And absolutely, we support that. And part of that continuum can include detox and long-term treatment. It's just a continuum of care. This is not an end-of-the-line treatment, and people can move along the continuum as their circumstances and their lives change.
Great. Thanks, Dr. Scott MacDonald, for your time today.
You're most welcome.